thing he asked for last year. And obviously, evidence is what drives things, and this is evidence, but it may not be something that's needed in every case. Should it be used selectively? But, well, if you're asking to use it selectively, you're still talking to the hospital administrator to have it on the shelf. And when should this be used rather than a simple aspiration catheter? So that trial hasn't been done yet, but it's an interesting question, and the data I thought was pretty convincing. The SORT-OUT 3 trial was a huge trial looking at large groups of patients treated with different types of stents, the Cypher sirolimus and the Endeavor with the zotorolimus, and they looked at indications for angina, and it was a relatively recent series. And it turns out that the mortality was actually worse in the Endeavor group, statistically significantly, but barely so. And the cardiac mortality, that was all-cause mortality, was not different. And in terms of definite stent thrombosis, which is sometimes an arguable issue, there was slightly worse for the Endeavor. And in terms of myocardial infarction, also slightly worse for the Endeavor in this trial. And again, the series was large, and this was 18-month follow-up, 2,300 patients. There was a panel discussion about many of the various stents and the outcomes of these stents, and Steve Windecker from Switzerland put this slide together and gave it to George, and looked at the different databases that we have, the Endeavor 3, the SORT-OUT 3, the ZEST, and the overall, which is basically a pseudo-meta-analysis, looking at which stent is favored by the data. And in terms of the relative risks, it turns out that the simple SES is the better one. But in terms of a relative risk, Endeavor 4 versus ZEST, the favors the PES stent. Now, at all-cause death, what does this show? Well, unfortunately, it shows that everything is clustered pretty tightly with slight favoring of the SES in this trial. And again, the ZES versus the PES, there was very little difference, and I wouldn't even call it, but they called it favored PES. So we don't have huge differences here in a lot of these. So there was enormous debate, and unfortunately not a lot of answers in terms of those particular stents in that particular trial. Now, this was a very widely anticipated study that came out. This was the left main compare trial out of Korea, presented by Sung Young Park. A very interesting study. They took 1,000 patients and basically randomized them to either surgery or left main unprotected procedure. And it was 1,000 in each group, beg your pardon. And this was followed from 2000 through 2006, and they had two eras where the first era got bare metal stents, the second era got drug-eluting stents. And over this period of time, this is their blockbuster, which is that they did not notice a difference in death, PCI versus CABG, in the cohort that they could match across the board for severity. How about for death, Q-wave infarct and stroke? Again, no difference. Target vessel repeat revascularization was significantly different in the stent group, requiring a significantly more repeat intervention event. So what does that all mean? Well, I think it means, and the other thing that was a nuance about the study is that the cardiologist decided which patient got stented. It wasn't randomized, and it couldn't be randomized because a lot of clinical judgment needs to go in to decide, can we do a simple, is it a good anatomy for a left main event? Another issue is that the surgical arm had about a 92 to 94%, if I'm not mistaken, LEMA use, which is good. It should be at least 90% of coronary surgical patients getting a LEMA. However, we know from the data out of the Cleveland Clinic that the greatest benefit is shown with arterial revascularization and the number of arterial revascularization conduits used. And that divergence happens more over time at 10 years and 20 years. So I'm hoping this will be followed out farther. And it's possible that the option, well, it's possible that we can see guidelines rewritten, in my opinion, as a basis of this study, that left main will no longer be a second, you shouldn't do it first option. I think it is an option that you can have dialogue with the patient about. And I think informing the patient of the various risks and benefits of both is important, and every patient is different. And I think there may be a divergence if more arterial conduits were used, and there may be a more dramatic lack of change over time if more drug-eluting stents were used from the outset, which are now being used more in that trial. So that was pretty dramatic. This is the Celestin trial looking at whether or not we should use triple antiplatelet therapy versus double antiplatelet therapy. And they also did another arm looking at statins and whether or not that's going to benefit patients on the long term. It was a little complicated study, but they basically wanted to look at whether or not adding an additional antiplatelet agent was going to decrease adverse events in patients who underwent management for their coronary syndromes, PCI, and follow-up. And the main issue is that there was a slightly higher, but not statistically so, increase in composite cardiac death, non-fatal MI, ischemic stroke, and total late revascularization in the double compared to the triple. So it was tending to show perhaps a slight improvement when Celestin was utilized in terms of an additional antiplatelet agent. And there was not a significant difference in bleeding in their series. But it wasn't a ringing endorsement of this, but it was an interesting study, and there was discussion about it and whether or not people are going to start using that agent as a triple therapy. I'm not sure that's going to happen, but it's another agent that now is being considered. This was an interesting study of 1,000 patients, the ISAR Test 2 study flow. This actually came out of Turkey, and it was looking at the Cypher versus the dual drug-eluting stent, where sirolimus is one of the agents, and the other agent is different style, chemical, and then the Endeavor stent was being included in that as well. And the interesting thing is that they were using binary angiographic restenosis to take the guesswork out of it. And interestingly, the patients who at 6 to 8 months had restenosis and there was good follow-up catheterization showed the Endeavor group had the worst. And the dual was perhaps slightly better, but not statistically so. And death or myocardial infarction, they were pretty clustered together and not statistically different from one another, although there was a trend towards the dual drug-eluting stent to be slightly better. And stent thrombosis definite at 2 years was very similar across the board, and when you look at the definite group with, again, a slight and interestingly, in that one, the Endeavor was a little better. So here comes the confusion again, even though it was a large study with numbers to power conclusions, hopefully. Target